Good morning, everyone. I'm Jessie Lewis, the clinic coordinator. Welcome back to another week of our Cardi-OH clinic, your patient with diabetes at risk for heart disease, a series of case discussions. We are well through this series. We've got quite the agenda today, so I'll go ahead and just hand it off to Dr. Rao.
Thank you, Jessie. Thanks to everyone. We are coming to the close of this series. It's been really exciting. It's been a great learning opportunity for me, and I hope it has been for you as well. So today we have two lead discussants. Karen and Chris are going to talk about both of our cases, and Adam and I are going to present some information about food sources as well. The cases are really fascinating. I especially like the case about another young man diagnosed with type 2 diabetes. It's kind of heartbreaking to hear about it, and apparently he's had it for several years. So I look forward to Karen and Chris's thoughts about this as well. These are our disclosure statements, which you can read and will be available after the talk as well. Reminder to use patient-centered language as always when it comes to gender, race, sexual orientation, etc. And we're going to talk today about food sources, diabetes, and cardiovascular health. And I present this talk from many different contexts because I've been in this space for a long time. I was the chair of the American Heart Association's obesity committee and worked as well on the American Heart Association's Rethink Your Drink campaign, which started about almost 20 years ago. You might remember the Clinton Foundation had started some of that work back then. So I've been an advocate for better quality food, but I want to challenge some of the conventional wisdom around this. So our objectives are to describe how available food sources influence cardiovascular risk, taste preferences influence body weight and control of type 2 diabetes, and describe the impact of public health efforts to improve the healthfulness of the food supply. So Adam and I are going to do a tag team on this. As I said, some of this is going to challenge conventional wisdom, and I'll explain why that's important in a moment. So we already know about disparities, racial disparities, gender disparities, and obesity, rural versus urban. They've been around a long time. So the overall adult obesity prevalence, this is from 2018, is 42.4%, astronomically high, of course. The highest rates are among African Americans, followed by Latinx people, and of course, Native Americans have very high rates of obesity as well. So if you think about this, and I don't expect you to be able to read this, what is driving the high rates of obesity in different groups? These are consumptions of unhealthy foods in different groups over time. And essentially all it's saying in all of these cases is that vegetable fruit consumption, raw food consumption has not improved, and consumption of unhealthy foods has increased steadily. So we don't need to get into the details, but that's the essence of this slide. Here's another example of it. And what you'll find, for example, is that it's not always the case that there are large racial disparities in consumption of healthy foods. So for example, you'll see a trend towards less fruit juice being consumed among all three of these particular racial groups. And that doesn't mean that other sweet beverages aren't being consumed, especially among Mexican Americans, where they have quite a variety available in their communities. But consumption of whole fruit has increased as well as the food supply has improved. So not everything is bad news. Here is the bottom line message that I want to bring home to you, and it's one that we often use in our Fit or Me obesity program. The number one thing that drives what people eat is how it tastes. Here's a thought exercise for you. Let's say you are at a medical conference, and I haven't been to one live for some time now, but they have like a buffet style lunch available to you. And you have promised yourself that you're going to stay away from high fat, high sugar, high calorie desserts. But at the end of the buffet line is your absolute favorite dessert. It's the Black Forest cake or whatever it is that you really, really love. We are all educated healthcare professionals with a passion for this. How many of us can honestly say we would forego that dessert on that particular day? I think some of us would, but a lot of us would not. Imagine that you are living in that environment 24/7. And yet we expect our patients will say, well, you just need to cut back on your sugar. You need to stay away from these items, etc. It's not that easy to do. Okay, so taste is the number one driver. Price is the second, and convenience and healthfulness are ranked a little bit lower. This has barely budged over the last decade or so. So price is something that food companies started to take advantage of back in the 1980s with the phenomenon of supersizing. If you drive by a 7-Eleven or a Circle K, you can see any size soft drink for 99 cents. What size do you think most people are going to pick? Of course, because they have the notion of value for money. The other factor, sustainability, whether something is organic or fair traded or whatever, those are concerns of people around here in Chagrin Falls, but for the most part, not for the majority of folks out there, unfortunately. So that's a very low priority. So keep that in mind. Now, there's problems with this taste phenomenon because taste preferences are often determined in early childhood. By the time a child can tell you what he or she likes, which is, concretely, they'll change their mind at age 2 all the time, but it was around age 3 or so, their taste preferences are set. And therefore, the way to influence what we eat has to begin early in life, and it has to be targeting the sources of what foods are available, and that's usually through marketing. So this has been shown over and over again, and yet people still have a lot of discomfort with this. Giving the poor easy access to healthy food doesn't mean they'll buy it. In fact, it means that they won't buy it in general. Classic experiment from Burlington, Vermont. Not a diverse community, from the 1990s. They put, it was a food bank where they got donations of bread from local bakeries. They put plain white bread that sells for, in those days, about $1 a loaf, next to artisan whole wheat sunflower bread, which sells for $4 or $5 a loaf, right next to each other in the food bank, which caters, of course, to low-income families and individuals. And overwhelmingly, the cheap white bread was the bread of choice. There is no cost difference, right? They're both free. There's a big difference in nutrition content. It's the taste. It's the taste. It's the taste. So let's not lose sight of that when we counsel our patients to say, well, if you just ate more healthy, fruits and vegetables, you would be so much better off. Of course they would, but it's not as easy as you think. We built it and they did not come, and food justice, which I'm going to end with before I turn things over to Adam. So this is a common phenomenon. So you've probably heard a lot about food deserts and bringing supermarkets to poor communities, et cetera, et cetera. And I think these are noble aims. So, I don't know of any recent Whole Foods here in Northeast Ohio that's gone up. But when I lived in Chicago a few years ago, they put one in Hyde Park, which is, of course, the home of the University of Chicago, but also is in the south side of Chicago, which is an economically challenged community. And when I lived in Pittsburgh, they put one there as well. And the benefits are significant because they employ a lot of local people, first of all. And some of the foods are not terribly expensive, and at least it gives people a taste of what high quality food could be like. However, does it actually influence what people consume overall in obesity? Probably not. I made the joke that the only people I've seen in the Hyde Park Whole Foods at University of Chicago or University of Chicago faculty and medical residents and people like that. So that doesn't really help the local community from a nutrition standpoint. The other thing they found in the city of Chicago is that within 1 mile, you can buy anything possibly that you could possibly want. The other fact is people seldom buy food where they live. They often get it on the way back from work. They get takeout, they get restaurants. They can be from many geographic locations. So food desert is very, very difficult to define. So what is the right approach to this? And Jim and I and others held a workshop on obesity in African-American women this past summer. And, one of the key themes that emerged is that, hey, things are being marketed to poor communities in rather aggressive ways. And I know we have a weight management series coming up in the winter, beginning in late January. We'll talk a lot more about it at that point. But advocacy, I think, is the way to go, keeping the science in mind, right? So it doesn't matter how much healthy food is available in a community or how much healthy food you consume. It's what you don't consume that's important. right? You might have a vegetable stand, but if it's next to Sonic Burger and the Sonic Burger is jam-packed, you're not going to have any impact on this issue whatsoever. So lobbying, especially for healthy food for children, has been a major passion of mine for a very, very long time. I actually helped develop advertising standards for foods for the ABC network. This is going back about 10 years, and you can Google that, and the guidelines are very clear. Unfortunately, they were voluntary guidelines, so ABC adopted them, I don't think, and other networks adopted them, but to a much lesser degree. And you can watch this video at your discretion. This was my congressional testimony in 2014. President Obama wanted to regulate the nutrition content of competitive foods in schools. So schools can sell, they have the USDA approved lunch, but they're allowed to sell chips and burgers and whatever else, right? And that's how they make their money sometimes. And the first lady at the time, who actually worked at the University of Chicago on the Urban Health Initiative, was interested in promoting some nutrition standards for this other set of foods. You probably can guess the outcome here. It went absolutely nowhere, no interest whatsoever from our lawmakers in this idea. So here's some potential strategies moving forward. So food justice is a hot topic. It's something I'm interested in. I just went to a literary conference where some of my ideas were well received, but they actually said, we really like you to write about food justice. And I kind of said, that's a big, huge topic. And it's not something that interests everyone. But this is one definition of food justice from Mercatus. Going back a few years, it's the communities exercising their right to grow, sell, and eat healthy food. Healthy food is fresh, nutritious, affordable, culturally appropriate, and grown locally with care for the well-being of the land, workers, and animals. The original idea of food justice actually comes from agricultural workers. You've probably heard of Cesar Chavez in the 1960s and 70s in the United Farm Workers Union, trying to improve conditions for those who grow food. And Eric Schlosser, the author of Fast Food Nation, made a very bold statement in his book, and he goes, what difference does it make if it's organic or not, if it's grown with slave labor, was his statement. And so food justice originally was intended to improve the conditions of those who grew food, who earlier in the 20th century were overwhelmingly Latinx migrant workers, rural workers, and African-American migrant workers as well. However, it's come to mean something quite different now. So food justice is generally having access to healthy food, which I don't think, as I've made pretty clear, is enough, right? I think it's people taking a stand against unhealthy food, right? That's the difference. That's what's missing now. And I've said this many times in many environments, that in poor communities across this country, many people have lobbied successfully for better policing, better public transportation, better housing. You think about removing lead from schools and pipes and how much work has been done. There's still a lot of work to do, but still McDonald's, Sonic Burger, Chick-fil-A, whatever it happens to be, are the dominant food sources in communities. And that's something that I think people need to take a stand. So food justice can also be defined as involves refusing to purchase and consume unhealthy foods which are marketed and sold aggressively in poor communities and communities of color. Now, we don't have much time to go into this, but in the winter, I will talk to you specifically about how things have been marketed to poor communities. If you go back to the 70s, there was a time that McDonald's only featured African-American children in their print ads. And that was deliberate. That was a conscious attempt to win over young consumers, of course, grow on to become adults as well. So I will stop there and turn things over to Adam.
Great, thanks, Goutham. So this first slide I have is just a sort of high-level overview, trying to contextualize food and food environments as existing in a set of broader environmental circumstances, mostly socioeconomic circumstances. And I like to point out that most of our efforts historically have focused on this yellow bar toward the right of the diagram. So like most of our solutions in the health care system have focused on, individual level solutions, which can have some benefit, but really can also be constrained by opportunity constraints at higher levels of ecology. Sort of tying closely in with what Goutham said, neighborhood socioeconomic conditions influence both cardiovascular disease outcomes, diabetes onset and management, and food retail environments. And I'm going to talk mostly about food retail environments today. This is, sort of giving that socioeconomic and health general context. It's a figure from some of my past work, and it's just a shot of Northeast Ohio. There's about 14 counties, I think. Well, actually, so the right pane, actually, this looks like it's just Cuyahoga. And so what you see is circled there are the two neighborhoods at the census tract level that have both the highest and the lowest life expectancy, respectively. And what we see is they also vary drastically in terms of the socioeconomic conditions of those neighborhoods. And that pattern is evident across the entire state of Ohio. And so that pattern is somewhat related to food environments. So next slide, please. And the pattern that I'll show you in terms of food environments for the state is going to be based on this measure called the Retail Food Environment Index. And so we've heard the word food desert a couple of times today, and most folks are aware of this. Other folks have used this phrase, the food swamp, which is sort of the stores that have fast food, convenience stores, corner stores, lots of unhealthy foods. And this is a measure that has been popularized by the CDC, where we look at the ratio of unhealthy food outlets to healthy food outlets in a particular area. So here, a higher number is a higher concentration of unhealthy food outlets. Next slide, please. So we see when we see Ohio as like actually sort of a disaster zone in terms of healthy food environments. So the red areas mean that there's no, just if it's straight red, there's two sort of red colors. One's a shaded red, but if it's just red, not shaded red, that means there's no healthy food outlet within that entire census tract. Some of those census tracts in Ohio are an entire county. So we have entire counties that don't have a single healthy food outlet in them. You'll notice a big swath of these in the southeast part of the state, where we also happen to have the highest rates of obesity, diabetes, and poor cardiovascular disease outcomes. The shaded red areas are actually those that have no food retail outlet at all. So that means there's not a single place that sells food, healthy or unhealthy. You have to kind of squint to see those shaded ones. They tend to be clustered in the rural parts of Northeast Ohio. There are areas where there's no retail food for sale at all. But what you really see in this figure is sort of like a tale of two Ohio's. One, which is sort of how Goutham spoke of Chicago, where like there's just like a bajillion places to buy food, and another where you can't buy any food at all. And so I think this is very consistent with, so in most cases, all of the blue areas, the yellow areas, there are lots of options and taste drives outcomes. But in some places, particularly rural parts of the state, there's really nothing there. You have to drive a really long way to get any food at all. Next slide, please. So we also know that this particular measure has a compelling relationship with diabetes prevalence. This is example study is from California. This has been repeated all over the country. And so what we see is about a 25% higher prevalence of diabetes in areas where we have the highest concentrations of these like food swamps, where there's way more retail outlets that sell unhealthy foods than healthy foods. And I think this really gets to that component of food justice that Goutham was talking about, because like if you had even options and taste is driving everything, that's one thing. But when you sort of tip the scale and you have this unevenness of food availability, plus people often prefer the taste of unhealthy foods, that it really drives disease burden and outcomes. Next slide, please. So I love these photo voice studies, and I have just a couple slides of these. This is a photo from a food environment study in South Africa in a rural area. And this is just sort of what I imagine. Oh, I'm sorry, my camera's gone off. The lights in the room I'm in here case like went automatically off, so I'll be in the dark for some time. This picture, this could be rural Ohio, right? Like a photo that somebody would take where there's no place to get food, and the place that they might buy food doesn't sell any healthy food. Next slide, please. And so this is sort of, the view of a place that sells healthy food is attractive to people, and we know from studies that there are folks in Cleveland who, in one of Dr. Boland's studies on produce prescription, where they prescribed healthy foods to persons with hypertension, what they found was that there were many participants in the qualitative component of that study who were in their 50s, right, had high blood pressure, and they had never tasted a blueberry, right? They got a prescription to go to the farmer's market, and in 50 years of their life in Cleveland, they had never had the taste of a blueberry in their mouth. The lights are back on. It's weird building. Next slide, please. So to begin to wrap things up, people who live in poor food environments consume more weekly servings of sweetened beverages like soda. People who live in poor food environments consume more fast food. And at the state level in Ohio, neighborhood influences account for millions of additional unhealthy meals per week, right? So like, we're not talking about like a small number of meals, right? We're talking about like millions and millions of additional meals. I think I was looking at the chat and what Chris's point about the food you don't consume has like zero nutritional content for you. And this concept of food justice is like, it's just a brilliant and wonderful pathway to engage communities in sort of fighting back against the unhealthy food environments that have set up shop where they live. Next slide, please. It's really important to point out that improvement is possible. There have been multiple Northeast Ohio studies on efforts to improve healthy food availability, access, and cost. Those efforts are generally associated with some small improvements, whether the outcome is A1C, whether the outcome is blood pressure. What we see is produce prescription programs, farmers market partnerships are generally associated with small improvements in outcomes. The things that are most likely to show improvements tend to be those that jointly make a partnership between primary care clinics, community members, and retail, often farmers markets, but not exclusively. Sometimes there are some clinical practices in Cleveland that have partnered with the grocery store next door. And so that, doctors actually talking to the folks in the retail food outlet about how they can come up with a program to help their patients eat healthier. And then the last thing I'll say here is that activity-based understandings of food environments are really needed. And this gets at like people eat where they are, not just where they live. And so really thinking about where people are when they eat. School-based programs are incredibly important for children. But employer-based programs are also absolutely critical. Next slide, please. So to sum up, the 4 pains of this figure from Academy of Medicine are great. We need to increase healthy options, reduce deterrence to healthy behaviors, build community capacity, and improve overall economic resources. Next slide, please. And then the last thing I'll say, just because we focused on this in a past session, like screen and refer models of social determinants of health, including food insecurity and healthy food availability, have some potential value. They are increasingly common. if we're going to do this in food, you really need some sort of local food partnership. Metro Health in Cleveland has a primary partnership with the Cleveland Food Bank. We have a food pharmacy on site where patients can get a prescription for food and they can go pick up food in the health system. There is some small benefit to these approaches, and certainly for a person who has no food at all, it can be really valuable in providing them with healthy food as opposed to sort of pure foods of convenience and taste that they might be able to get their hands on. But really, to do any of these, you need to maximize the benefit by partnering, which isn't always easy to do, right? Reaching out to those other organizations outside your clinic, your hospital, your health system can be challenging. But I think this advocacy layer is a really important one for all of us to consider, especially given that big map of the state. It's going to take more than just screen and refer models to solve that situation. And I think that's it for me. I'm really excited about the cases today.
Thank you, Adam. I think that Adam kind of ended a little bit on a hopeful note, which I think is fantastic. I just want to point out that one hopeful note is industry itself. So some of you probably know that the amount of sugar in cornflakes goes down, I think 1.5% per year, which is something that children and adults don't notice. If it was too drastic, you'd notice. I have a friend who's a food scientist who says there's a certain threshold, kids just won't eat something. So it goes down 1.5% per year. And Jackson's not on the session today that I can see, but he's pointed out that in the UK, everything is a little less salty than it is over here, and that's deliberate. So going back about 10, 15 years, they started to decrease the amount of salt in foods, and they've seen a significant decrease in the incidence of stroke as a result. So I don't think industry should be viewed as an enemy here. Some foods are invariably unhealthy and will always be and should be avoided, but they can also be partners in this as well.
Great, thanks everybody. So you'll have your usual post-clinic survey in your inbox. Please just complete this by tomorrow at 5. And then just a reminder, we will not meet next week since it's Thanksgiving. So we'll resume December 2nd. And then just a final reminder about another cardio opportunity. Our webinar is coming up on December 1st. That's Wednesday. It's over the lunchtime slot. The topic being management of type 2 diabetes in the adolescent and young adult population. So if you're interested, please feel free to go to cardio.org to register. And I think that's it for today. Again, everyone have a great holiday, and we'll see you in a couple of weeks.
Thanks, everyone.
Thank you so much.
Bye-bye.